And I believe we are live. Wonderful. Welcome to Wellness Wednesdays. My name is Dr. Sergey Leo Shealy-Sorin. Dr. Shealy couldn't be with us today, but we do have, well, he's doing all right. Just saying hello to everyone. Mr. Doctor
That's like a field
Chuck
promotion.
Reiner. Yeah. Well, today's topic is quite fascinating. Working with back pain, working with therapy, and specifically spinal decompression, which is, let's start talking about a few things. Chuck, I know you've been a guest on this program previously, and as far as I'm concerned, you are the number one occupational therapy beyond extraordinaire.
Thanks.
So a little bit of background on who you are before we get into what decompression is, and so that we can get a foundation of what it's all about.
Sure, absolutely. So I'm an occupational therapist, and I've been an occupational therapist now for many, many years. I developed an interest in chronic pain, probably 20, 23, 5 years ago, a long time ago. So I started taking a lot of education, learning how to deal with patients with chronic pain. And so to the point where that became my specialty, that's what I like seeing is people that have these unresolved healing issues that are keeping them stuck in chronic pain. That's why I first got associated with you, because I started looking at the body more holistically and from a holistic standpoint. And that led actually me to kind of leasing space out of your office now to provide care for patients that are in chronic pain, which I really appreciate. When I was looking to that level or looking in those areas or arenas and dealing with chronic pain, I kept running across decompression time and time again. And so in a previous job, we did decompression. And so when I came here, I wanted to offer decompression services also. But I wanted to research, like, what is the best decompression on the market? What does the research say out there? And that led me to a company called Spinal. And Spinal, what I found out is that they're the leading company for spinal decompression. They're also the only company to have a patented kind of trademark process in which the decompression is provided that separates it kind of far and above other decompression tables out there. And so for me, it's like, if I'm going to continue providing this kind of service, providing decompression, I wanted to find, one, the best table that I could to get the best results for my patients. And second, the one that had the most research behind it, because that's important to me. You want some, as when you can get evidence-based practice, you want evidence-based practice. It's not always easy to get, but in this case, it was easy to get.
Wonderful, wonderful. And actually, speaking of research, and I'll just mention this briefly, but I was actually involved in the investigation with IDD, which is the decompression chamber that we're talking about. And Dr. Shealy is actually considered a godfather or founding father of the on the medical end of decompression therapy. So, I mean, this is a wonderful continuation of where Dr. Shealy started this approach and just carrying it on. There's actually, as a matter of fact, I'm just going to jump in real brief here.
Sure.
And I can't say too much about this right now because there's an active process going on. I am actually working with MSU, Missouri State University, on another research project with AccuSpina device, and it has to do with a combination of how does it work in terms of, like I said, I won't go into too much detail, but there's a significant consideration to show the benefit, especially in the regenerative capacity, because the nature of our practice here is functional, holistic, regenerative. And we have a few programs in common that we are working together.
We do, and it is exciting because what we hope is when you see people, so the AccuSpina have what they call IDD, and IDD is intervertebral differential dynamics. And that's how they look at treating the disc, which I'll get to in a little bit. But it's like when you look at cellular function and improvement, you expect to see a few cellular mediators improve as they physically improve. And part of the research that we'll be looking at is kind of trying to quantify that. And so it's really, really an exciting topic because that takes out of any kind of a subjective perspective from the patient. You know, are they feeling better today or not feeling better today? It's like, what are the cells doing? And so it's really exciting.
And that's wonderful. one of the things that Dr. Shealy has been all about is research, and one of the power. That's why he's a powerhouse, because there's no statements without data.
Well, if you look at the data on decompression therapy, a lot of times, most companies, including AcuSpinal, most companies will recommend 20 sessions of decompression therapy. Well, they got all decompression companies have that 20 mark based on research that Dr. Shealy did probably back in 2007, 2009, sometime in that time frame.
That's about right. Yeah.
So it's interesting. It's kind of coming full circle, because he's the one that actually set the bar, and through MRI investigations and decompression determined, well, what's the best treatment time frame to get the most efficient use of this machine to improve disc function. And he's the one, through his research, that determined this 20 mark. And that's what we do, and other decompression companies do even today.
So that literally is a foundation for IDD, for decompression.
Absolutely.
So let's step back a bit, and let's just talk about who is the right client for IDD. In other words, what are who needs to be, who should be thinking about this kind of therapy, and why?
That's a great question. I think we have to almost break it down into two pathways. You have what maybe more conventional medicine would tell you, and what more holistic medicine would tell you.
Shall we do the both approaches so that people are not surprised when they talk to the conventional docs?
Absolutely, absolutely. And I'm not saying it's good or bad. It's just different. It's just a different philosophy, different approach. So what'll happen, let's take low back pain, and let's take out accidents and injury, right? Let's take about people kind of wear and tear. So what is wear and tear? So with age, we may have your disc may get a little bit shorter or thinner, right? Called degenerative disc disease. And you're not quite as tall as you used to be. You don't have as much space.
Yep.
As that happens, you don't have as much nutrition that goes to the disc. You can have something called, well, let's just make it easier. You can have arthritis of the facet joints on the outside of your spine. You can have
Stay tuned, folks. If you can hear me, stay tuned. And that's what it's all about. If we can figure out how the body works and the blueprint. Okay, we're back on, by the way. So I hope we didn't miss anything, but we're going to just continue right into this. So please.
Yeah, we may or may not affect you.
So round three.
Let's go round three. Guys, sorry, this is becoming like a boxing match in different rounds. So we're having some internet connectivity problems, as you can tell. Sorry about that. And we'll kind of press on as we can. So I'm not sure exactly what's been cut off and what hasn't. So I'm going to proceed. If there's something that I was in the middle of and you have a question, just type in the question. We'll try and get back to it. So you have this degenerative process that the standard method of diagnosis is they'll do an X-ray, they'll do MRI, they'll look at your symptoms and say, well, it could be a normal part of aging. Your pathways could be pain management, could be surgery to maybe do a fusion to try and get the pressure off. But that's what you have to choose from. In the holistic world, we're like, well, wait a minute. You're having these degenerative changes because you have more laxity in your dorsal spinal ligaments.
Cool.
If you have laxity in those ligaments, what can we do? Well, first we have to get more hydration to the disc. How do we do that? Well, that's where you get decompression. And decompression is totally different from traction. Traction does not...
Thank you for making the distinction.
Traction does not relieve interdiscal pressure. There's no research that shows that traction relieves interdiscal pressure. There's a lot of research that shows that decompression does. And what's the difference? The difference is two things. One, the decompression is computer guided, and so we can specifically target the area that we're looking at. The second one is that it incrementally increases attention. And so it tries to stay under the radar and almost trick your body into not resisting this pull. And so if your body's not resisting it, you have to have far less pull than you would say on a conventional traction unit.
And that's safety as well as efficiency.
Completely. Both
Yes,
are correct. And so as we have this model, you do decompression to increase the space that the disc has. And as you increase the space, the disc can actually get more nutrients. And the disc can actually kind of puff up a little bit again. And so what happens is you're providing an environment for the disc to either heal or improve in its function. And then ideally, after you create that better environment, the next step really would be doing some type of regenerative medicine. So you maybe do platelet-rich plasma injections to help stabilize those ligaments to make you have a more functional spine. So what we see is we want that disc to get as much nutrition as we can. The decompression creates what we call a negative disc space. A negative disc space invites that disc to want to centralize or move back underneath or out of the way of those spinal nerve roots that it's pressing on, causing all the pain. And so that's what it can do. Now, Acuspina, well, we use that is because it has another proprietary part of it. It has an oscillation component. Mm-hmm. That oscillation component is very unique and really critically important because what happens is, as it does the decompression, it will oscillate at a certain rhythm. And that oscillation, it's kind of like rocking a baby. It's going to help do two things. It's going to take those smaller muscles
if we're still, actually, we might be back on again. Another possibility is if we're truly having some internet issues as we are right now, which would be terrible because the topic is so fascinating, is we can record this and have it available that's not live so that the information is out there. But if we can continue, let's continue. Unfortunately, as we said, there are some things that are in our control, some things that are outside our control.
This is one that's outside.
Then that's outside of our control. And on the holistic end, this is what I always say, focus on the things that you can focus on, because then you'll be all right. And then don't stress about things that are out of your control. Just do the best you can, and maybe something even better will come along.
Absolutely.
But we are back in. So
we're back in. So kind of in summary, from a holistic standpoint, when you have low back pain, what you look at is, okay, mechanically, how can we improve the environment? And you improve the environment by getting the disc to have more nutrients, getting the disc to have more space. When that does that, the muscles don't have to guard. If the muscles aren't guarding, then the nerves aren't as irritable, and you have better mobility.
And I'm going to speak as a patient, as a client, and I had a session, and I need to get on your schedule as well, because I have certainly lots of neck and back things of my own. But very interesting experience, and maybe you can comment on this and perhaps some other patient experiences, if you don't mind. So you were taking care of my neck.
Mhm.
So I was in decompression for the cervical,
Mhm.
and I actually fell asleep during the session.
Yeah.
Now, there is a connection between parasympathetic, in other words, in the cervical spine, and when the neck gets fixed, so to speak, you relax.
Yeah.
Um,
If you're, it's a very good point. If you're in pain, and it's not that uncommon, if you're in pain, once you decrease that pain perception, then your body doesn't have to be on guard all the time. And so sometimes you have an immediate biofeedback. Biofeedback is, oh, I can check out now because I don't have to be concerned about protecting my neck because it feels good at this moment. And so a lot of times that you do see that with patients, and which is great, because what we want is we want them. It's not about going through a treatment. It's about getting your life back. It's about being able to pick up your grandkid, being able to play golf, being able to do the things that you want to do, instead of being told, oh, you can't do that. Oh, you have a terrible back. Oh, this won't work. That won't work. That's not the case. What you have to do is find the appropriate treatment.
What most people forget is that, and this is what unfortunately conventional medicine has a strain on this, is that it became about the modalities in the conventional world. What about MRI? What about this? What about surgery? What I want to bring this back to is, let's bring it back to the patient. Let's bring it back to the person. Not even to say patient, just person.
Mm-hmm.
Why are we in this? Why are we in this field? Why are we treating people? Why, I know why you and I are in this because it's to help.
Mm-hmm.
And so it's not about. So ultimately, it's not even about the device. It's about what the device is going to do for the quality of life.
Mm-hmm. Absolutely, it's about getting the person's quality of life back, about what they want to do, and this is a great method you can do that. As we were looking at researchers, one research they saw over 500 patients with chronic back pain, and they had a 92% success rate with acuspinal decompression. That's enormous. Well, I mean, what most medication success rates, 50%? They consider that successful?
Probably less than that, actually. And the crazy thing about this is, it's not just the pain, it's the quality of life. Mm-hmm. When you're in pain, you don't exercise, you don't get to utilize the body. When you stop utilizing your body, what's the first thing that happens? You also have a very active occupational therapy practice. You work with a lot of different modalities. Now, mm-hmm. Chuck, this is a good opportunity to also mention some of the other things that you do in addition to conventional techniques, or I should say conventional occupational therapy techniques. You are above and beyond, and this is so. Let's expand a bit on that.
So you're right. In full disclosure here, what's helpful is, most of the time, if you're sent over for decompression, I am going to do other things to help you.
Yes.
And so to help you, again, for me on my end, it's again improving the environment. The environment is, I look at kind of structure first. Do we have segmental and appropriate mobility for both the spine, the hips, the knees, the ankles, the pelvis? Is that appropriate? The second, are the muscles guarding or not guarding? If they're guarding, they're almost always out of balance because you don't guard symmetrically. So some muscles are tight, some muscles are loose. You have to have a better balance. If you have the muscles that are guarding, then the nerves, again, it's supposed to glide 7 to 20% of the resting length. They're not doing that. So now they're more jumpy and irritable. And so in my field, what I do in my work, I try to improve those environments. So the mechanically, the patient is going to have a better environment for that body to be able to heal. Because how I look at these people in chronic pain, they're just stuck in a healing crisis. They're treading water and they can't get out. They can't get to that next level. They can't get to the next spot. And what I'm frustrated with, a lot of times what I hear other colleagues saying, okay, well, it's because you have core weakness. That's what we got to do. You have low back pain. We got to get your core improved. You won't have problems. I'm not saying core strengthening isn't important, but in my world, it's like 6th on the list I need to check off before I get to it.
Because the body's going to be guarding.
The body's going to be guarding.
Yeah, exactly.
So if the body feels it's in crisis and in pain and guarding, you're not going to strengthen through that. You can force yourself to do exercises and you can do them till forever, but they're not going to actually strengthen because your body won't allow it to happen. So there's no reason to put that first. I'm sorry.
Thank you, thank you, thank you. I appreciate that because personal story, and I guess just certain things that I learned the hard way. So when I was going through my personal recovery from the 21 crash, and I was basically near paralyzed at the time. I mean, I was paralyzed at some point, just could still move my toes. What happened was I was doing exactly what you were saying. I was, remember when you first saw me? So I was as soon as I got home post-surgical, it was just right after, I'm supposed to literally just sit in a chair and get up once in a while. But I was trying to go up and down the stairs, not very successfully. But, again, the first thing that you said to me?
Basically, what I said most to you during your rehabilitation is just no. I said no over and over again.
Correct.
Because we have two types of people. Dr. Sorin is kind of a type A person in the fact that he wants to do as much as he possibly can, which normally is great, unless your body can't hear it. And so your problem was your body was at the level to receive the inflammation. So you turn that progress, which would have been kind of strengthening under normal circumstances, and you turn it into inflammation.
Gotcha.
And it was more inflammatory. And then as you became more and more determined to get better, you just got more and more inflammation and got more and more pain.
And that means then the body froze even more.
Body freezes
like literally saying, nope, don't go there.
So the first thing we had to do with you is we had to back you off on almost really most of the things that you were doing, because it was just too high of level of function for what your body could process.
So on that end, let me just kind of jump in. So if you have a high functioning person who wants to do everything, and yet they're limited by pain, whether it's the degenerative or whether it's something or post injury, obviously not right after injury, but would IDD be appropriate for a person who is just recovering from an injury and wants to get better?
Oh, absolutely. Absolutely. If you're having back pain, especially if you're having radicular pain, this is something that's very, very helpful. And people look at, I guess I should approach this too. People look at pain differently. Pain is actually a gift. Pain is a gift to us because it keeps us out of trouble. And the acronym I love is PAIN simply means pay attention inside now. And so it's just an alarm. It's an alarm that's going off in your body that we need to know, okay, well, why is it going off? It's not random. It's not haphazard. It has either a visceral or a mechanical component. And when we find that component and correct that mechanic, then it doesn't have to go off anymore.
How do you get patients and clients who say, well, I'm just used to fighting through the pain?
Yeah.
What do you think about that?
You hear no pain, no gain in the military a lot from our veterans. You'll hear pain is fear leaving the body, and you'll hear those kind of those statements. And neither one are probably correct in the moment we're talking about healing. We're talking about healing. It's like we listen to pain. Pain is an advisor to us. It's telling us what we can and can't do. Now, most people will get better if they remain active. Mm-hmm. So I'm not saying that, okay, if you're in pain, sit down and don't do anything. That'll actually get worse over time, not better.
Yeah, frozen.
Yeah, frozen. So you have to have an activity level, but it's got to be appropriate to what your current pain level is. And if you are, then your body inflammatory mediators don't start increasing, they start decreasing, because then your muscles, your joint movement is activating your lymphatic system. Your lymphatic system's moving the swelling. That's what's supposed to happen over time. But people, I get it, they're impatient. They want to get back to their lives, want to get back to doing things and think, well, if I push myself, I'll push myself through this. And as a therapist of many years, I can tell you, you will not push yourself through nerve pain. The nerve will always win. In our system, the nerve rules supreme. It gets what it wants, right? So it will make your body twist out of position to get out of pain. It'll make your muscles spasm to get out of pain. Our nervous system rules our body.
Yes.
And so we can't with our mental thoughts or our determination, we can't try to superimpose our own beliefs on that, because the nervous system's still gonna win.
And I remember when I was back in college, I was in martial arts back then as well. Mm-hmm. So I remember one time I ended up with I broke my leg. So basically, what happened was I started exercising with my upper extremities even more so, just to balance out, because I needed to do a certain amount of exercise a day, right? Mm-hmm. And so then I hurt my upper body, and then I was out for just entirely. So compensation. The body will compensate to a large degree, and then there's secondary compensation and a tertiary compensation.
Yes, yeah.
In other words, so when I see people who are basically kind of like, like walking like this, there are multiple foci, multiple places of where they're stuck.
Yes. Yeah.
And it has to be worked on almost reversed in a retro fashion.
Yes, absolutely. So in our system, it's like, if a person comes to me, they're not and it's a little bit of semantics, I get it, but they're not a back pain patient. They happen to be a person that has back pain.
Thank you.
And it may not seem different to people out there, but there's a huge difference in that. Because with a person with back pain, that tells me you also, if it's chronic, you have other compensation patterns that you're dealing with. And sometimes the compensation patterns over time can be just as bad as the original problem, if not worse. And so if you come in, I can't treat that little 7 square inch segment of your back and say, okay, this is all we need to do.
Yes.
We have to look at your cranial system. We have to look at your cervical system. We have to look at your pelvis. We have to look at all these different systems that are going to be involved if your body's trying to compensate. And we have to kind of unwind that system.
Perfect. Let's talk about the other category of folks, the ones basically who do nothing. They get into a situation, could be post-traumatic, could be an accident, could be something, and then all of a sudden they go again, and this is classic, go to the doctor, white coat, again, nothing wrong with white coats, again, just that,
Sure.
Let's say the person here is the first and foremost, well, you're getting old. It's just, that's all there is to it. Your back degenerates, your joints degenerate, everything degenerates, and that's where you're heading. So don't worry about it. This is normal. Okay, and then this person believes that, buys into that, and I say this, buys into that because this is where control center comes in. In holistic, we talk about spirit, soul, spirit. We are more than anything that we know. I mean, just by far, control center, and then the physical patterns. So what do you do with the people who come to you and say, well, my doctor said there's nothing I can do, there's nothing I can do, and
yeah, it's very frustrating because I'm now in that category where my doctor tells me, well, you're getting older, that's going to happen and stuff. And I just don't agree with any of that. I don't agree with any of that because a lot of times what happens is they may be saying, again, I have friends that are physicians. I have friends that are more allopathic physicians, and they do a great job. They care about their patients. They try and do the best they can. But on this one issue, I don't believe that that's a diagnosis. Oh, you're getting older. I think what happens is that's an observation. And the difference is you can't make a diagnostic, prognostic example of someone saying, okay, well, you're getting older, therefore your back should hurt. Your knee should be stiff. You shouldn't be able to get up as much. You can't play golf anymore. I don't think that doesn't make sense to me, especially as a baby boomer that wants to stay active. As you know, a hobby of mine also is a martial art, and one of my
you were my instructor actually until I couldn't do Aikido anymore, right?
Until you had to have a little bit of fusion there. So
yes, sir.
We had an instructor of mine was 84 years old. He was 84 years old, traveling the country, throwing people in kind of like judo type throws that are 20 years old, and to him, he was no superman. He was no super individual. He just had a mindset that I want to stay active. This is what I want to do. I want to be active. And so for me, I do get patients a lot of times that say, well, have these limiting beliefs. And these limiting beliefs will be reinforced by, well, I went to my doctor for this. They said I'm just getting older. I have to live with it. So there's nothing I can do. And most of the time, that's not correct. Most of the time, there are things that we can do to help them because they're usually mechanical. They're usually things that we can improve. They're usually, when we talk low back or cervical spine, they're the same thing. There's the disc degeneration. There's a stenosis. There's the arthritis. There's different things that affect the spine. Some things we can change, then some things we can't change. But like you said, if we focus on the things we can, typically the patient gets better. And that's what we want to do. There's my favorite saying is by Henry Ford, and it says, if you think you can or if you think you can't, you're
right.
Probably right.
Yes.
And so if you think you won't get better,
yes.
You know what? I'm probably not stronger than your mind. And so if you have that strong belief and you want to prove me wrong, you can probably prove me wrong. But if you have an open mind that healing is possible, there's so many things that I see that people just don't have to live with.
Wonderful, 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 wonderful. Chuck, let me ask you: do you have any patient stories, recovery, anything that just burned into your being as a therapist, so that just things that people should know about, of course, without mentioning names.
Sure, obviously. So what I see is really, I see the same pattern a lot. I see radicular pain just means you've irritated the nerve root enough, and now that pain is traveling. Usually you've heard of like sciatica. Sciatica, kind of the pain goes down the back of your leg because you have an irritation of the nerve root. And so I have patients that come in all the time. They may be in like 7 or 8 out of 10 pain. They really can't walk. They can't do much. And usually after a few sessions on the Acuspina, which I wouldn't even call it decompression. If I'm looking at this machine, I'd call it advanced decompression. This isn't equal to other models. It's just simply not. And the patients, you can look up the research yourself. I mean, it says it for itself. But when they get on that, a lot of times they'll come in with a pain 7 out of 10, and they'll leave that same day with 0. Now they'll go back to doing their normal activities. The kind of pain will kind of creep back up again. They'll come back for another session. That's why you have to do multiple sessions. That's why you can't just do one session and you're done. You have to create an environment over time. And that environment over time can heal. And so it's just so rewarding to see patients that can't literally do anything. They can't hardly even get out of bed. And now they're all of a sudden, my pain, on a bad day, it's a 2, it's a 3. And it's so exciting because that's possible. We see that all the time. Patients that are in that type of pain, especially, there's 2 types of patients with back pain. There's people that have kind of back muscular pain. Pretty much all of us at one time have had that. And there's people with nerve pain. Not all of us have had that. When you have nerve pain, that's just a different animal. That's something that's going to stop you in your tracks and make you take notice. Mm-hmm. And so, in fact, a lot of times people that haven't had nerve pain but have had back pain think they've had both. But you'll know if you've ever had pain that actually affects the nerve, because it's just different and it's more intense. And so these people, unfortunately, they do feel they're stuck in a crisis that they can't get out of. But you look at surgery rates. The Journal for Neurosurgery, they say that really you have kind of, if you're having back surgery primarily for back pain, if that's the reason, yes, again, you have a 50-50 shot of improvement. Well, that's an extremely invasive procedure for a hope rate of 50%. Now, there's some red flags that mean if you have those flags, then yes, you are not a decompression candidate and you are a surgical candidate.
Exactly. Let's talk about those flags.
The main 2 that you see for low back pain are problems with bowel or bladder. Boom. If you're having back pain and problems with bowel or bladder, you know what? You don't need decompression. You probably do need surgery, and you should be seeing a surgeon.
Another example is not just the sensory, but the motor. In other words, the people who have weakness. Let's say, for example, if somebody walks in, or let's say they're able to walk into the office, and let's say they have weakness and pain in the legs, and the weakness is beyond the level of the pain. It's not the pain that stops them. They just don't have the strength. Mm-hmm. It could be one or the other leg or both. When that happens, that's a red flag.
If you have kind of what they call myotomal weakness or weakness within a certain nerve root pattern, then that can be a concern. Sometimes the hard part, though, is sometimes I see patients who've had back pain for years, and sometimes due to inactivity, they're weaker. And so then it's not really a motor nerve problem. It's just they're weak and deconditioned because they hurt too much. Mm-hmm. But you do have to differentiate. If they're losing muscle tone, if they're losing muscle strength, then that can be another red flag. And again, I've said this before, but I have friends that are surgeons. I have friends that are excellent surgeons. And I have no problem at all with surgery. I'm so thankful those people are there doing what they can do. Mm-hmm. I just want to make sure the appropriate people get to them.
Exactly. And just for an example, excuse me. So right after I crashed, I remember that moment. I was able to, with help, of course, before the situation set in, I was able to take a few steps, and so basically, in my mind, I was okay. So when I called my wife, immediately I said, I'm all right. Just take me home. And then I couldn't take another step. Yeah. Okay. Well, that wasn't a go home situation. When you do have an acute traumatic, or it doesn't have to be traumatic in a classic sense. Sometimes you're just walking and boom, you feel a sudden pain, and something ain't right.
Mhm.
And when that happens, it could be because of the osteopenia, osteoporosis. In other words, the bone is so brittle that even a step can cause a collapse. If that happens, that does require an evaluation. And I do want to say that if you haven't been diagnosed, or if you haven't been to a proper place where they can take a look and then see from a red flag perspective, such as emergency room, but also from a functional perspective, which is basically what we do here.
Mhm. So here, what's very important, like in our system,
Mhm.
you can't really, we won't put you on the decompression unit until you've had an MRI.
Are we on? Okay, we are now.
Sorry again.
Sorry again, round 3 or round 4, which is I'm not sure how many rounds, but that was great. We were able to get some information out there, so that's really is wonderful. Uh, since the internet is kind of not going too strong, I wanted to mention because Dr. Shealy wasn't able to come in today. Some of his favorite things as well. So our sponsors as well. So Coloma tart cherry juice concentrate, very good for you, tastes well, and anti-inflammatory. And if you're not getting your veggies, well, make sure you get your tart cherry juice concentrate from Coloma. And another one of Dr. Shealy's favorites is Spring Valley. It's a wonderful store, wonderful place for supplements here in Springfield, Missouri, and service is fantastic. They carry all of Dr. Shealy's favorites as well. Essentials, youth formula, magnesium, bliss oils, lots of different things. And one of the best things about it, great service. Now, so back to where we're going, and I think we lost another part during intermission again.
So I'll just briefly say this again. For our system, it's like if we're going to do decompression, we don't do decompression without an MRI first. And basically that MRI, of course, is reviewed by you. And it's like we're looking for any kind of red flags that could be a contraindication to their care.
And if there is a contraindication, then what we do immediately is we get you over to the right specialist, conventional wise. And speaking of stuff, so let's say if I came to you, right? Let's say if I didn't have stabilization surgery, let's say if I was stubborn enough to kind of to have somebody drive me in, and I have a spinal injury, how would you know whether you put me on a table or no?
So for me, if let's say you came in off the street to see me, I would do an evaluation. I would look for red flags through provocative testing. But before that, we would have to have you go out and get an MRI.
MRI.
So it's like, it's not like, hey, I feel pretty good. I know what I did. I just need this. There really isn't, I just need this. That isn't a category that we accept. What we accept is we have to make sure that the boxes are checked for you to safely get the treatment that you need that will be productive. And if it's not safe, it's not productive. So there's if you kind of Google decompression acuspina, there is almost zero injury rate. The injury rate is just so small. It's negligible, because through that company and through what we do too, we just make sure we match the appropriate person to put on the machine.
Wonderful.
And that's very important.
What other modalities do you use in conjunction with the decompression? So when a person has a back or a neck?
So for me, it's all about getting the person out of pain as quick as we can, right? So I'm going to treat that environment again, usually from a manual therapy basis. I'm going to help the patient learn nerve gliding exercises, because again, for the patient standpoint, they may not understand, like our sciatic nerve, for instance, again, should glide between 7 to 20% of its resting length. If it's not doing that, if I'm walking kind of half bent over, very stiff, taking very baby steps because I hurt, then that nerve is not gliding. If it's not gliding, it's not getting the nutrition it needs to heal. And so we have to help that nerve. Sometimes manually, I'll work on improving that glide if it's really stuck through the fascia and muscles. A lot of times, almost all the time, the patient will be given exercises to do also to try to improve that mobility. So at first, we need that mobility to increase. We need their patient's pain to come down. So step one, what we're concerned about is doing things to relieve pain. I don't do a lot of what they call modalities. Modalities are like electrical stimulation and ice and heat and things like that that patients may be aware of. And I don't do those because for me, they become more Band-Aids. You know, I maybe if I freeze an area long enough, you'll feel that you're better, maybe have less pain.
But just buying time.
Maybe buying time. I haven't mechanically changed anything.
Yes.
In my job, I'm supposed to be a professional. So in my job, I'm supposed to be able to do more than you can do for yourself at home.
Yes.
Yeah, I may have you ice at home, but you don't need to do that with me watching you. You know, what you need to do is take initiative and follow your directions that I give you. But for me, what you're expecting is me to have a different skill set to be able to help you out of pain and get these tissues moving better.
Yep. Another question that was asked of me, and I thought it was a good one actually to bring up here. You know how people have those at home? It's a I guess it does somewhat a decompression. It's you get back, you put your head back, head towards the floor, so to speak, inversion table.
Mm-hmm.
Yeah.
Mm-hmm. So inversion tables can be helpful for some people. A couple of precautions, if you have glaucoma, if you have eye problems, you shouldn't use it. If you have blood pressure, heart problems, you shouldn't use it. So there are a few contraindications for patients. But what will happen is, for some people, that can provide some relief because you're using the body weight to kind of pull on the segment that's having the problem. The difficulty with decompression, difficulty with inversion tables compared to decompression is if your problem, let's say, is at L4-5, but L1 and 2 are really, really tight, and L3 and 4 are kind of a little bit loose. When you hang on the inversion table, you may really stretch that L3-4. Your problem is at L4-5.
Gotcha.
And so you can't determine what level
Does it look like we're on round 4 or round 5? Well,
I think you guys are on.
okay, if we're on, yeah. Okay, round. And we're on round 4 or round 5. Okay, well, the interesting thing is we're just saying, and thank you for your patience in this whole process. We were just saying, so how many folks on the other side are going to have the patience and how do we say it? Just
the forbearance,
the forbearance to continue with this information is fantastic.
I do want to get this information out there because
Please,
people don't have to live with this kind of pain, and their choices, a lot of times they feel their choices either maybe pain management, again, wonderful people doing a specific job, or surgery, same thing. But they feel that those are their only 2 options. And the thing is, that's not their only two options. And the option that they're leaving out is this more holistic means of decompression and treatment, usually therapeutic intervention, that can make much more mechanical difference than the other two as far as the patient's function is concerned.
Perfect. And I do want to say, Dr. Shealy, he's the foundation for this podcast. He's the reason that, we are having this program to begin with. And for over 30 or 40 years, actually 40 years, I should say, he's been broadcasting the perspective. That's the reason that he went into the holistic field. That's the reason why he did what he did as a neurosurgeon. So from a TENS unit, from dorsal cord stimulator invention to
research on decompression.
And it makes absolute sense.
Mm-hmm.
Absolute sense. And again, I don't know what we lost or we didn't lose, but just again, the distinction and the difference between the differential, differential dynamics versus just the simply pooling effect is, as you said, and this is very interesting. I just want to bring focus to this. When you get on the inversion table or or you work with a conventional or with a basic, I should say,
like a traction
unit. We're not even going to call it it's not in the same category. No. Yeah, it's just not in the same category. Mm-hmm. Yeah, what you're doing is you're allowing the body to naturally, by gravity or otherwise, to lengthen. But what lengthens is not what you want to lengthen. What lengthens is what's the easiest to lengthen.
Correct.
So did I say it right?
You did, and it may be it's kind of like rolling the dice for your specific problem. You may get some relief with that, but it's not going to change the interdiscal pressure.
Right.
And so
that's the primary issue to begin with.
That's a primary issue to begin with. We need to create a negative interdiscal pressure. You can only do that through decompression. So while you may have symptomatic relief with like an inversion table, I haven't seen any research that shows that can actually decrease or create a negative disc space. And you need that negative disc space to get that disc to migrate back into where it belongs and quit pushing on those nerve roots.
You were in the previous place that you were at.
Mm-hmm.
You may want to say where, what it was or not.
Sure.
Again. Well, it is what it is.
I think we're back. So
I think
we had be here for next Wednesday.
I think we do. Absolutely. Yeah.
Good.
We're on.
So the company I previously worked with, they had their own decompression tables. And at the time, I thought they were good tables. When I did research starting out before I came here, before I purchased a decompression unit, I just thought that, I just want to make sure I have what I think I have. And I just found out that the tables I was using before were probably adequate, but they weren't the best on the market. And they did not have this oscillation feature. They also didn't have it like in the AccuSpina, the column moves up and down.
Mm-hmm.
So you can really more specifically on other units, when you have to adjust the bed, you're going to have to compress the spinal segment to some degree if you're changing the angle of that spinal segment. With AccuSpina, you don't. They lay flat on the bed, and then you can target externally where that pressure is coming from.
So literally just a target acquisition and
that's target acquisition.
Boom.
And then I can't say enough about, again, that proprietary oscillation component. because that makes such a difference. There's no other decompression units with it, and it's something that you can't mimic. So it's built into the program. It's built in the program to, again, help relax those core muscles, help relax or improve nutrition to the disc also. And it really separates decompression from advanced decompression.
Wonderful. And actually, as you're doing that, the concept of adding the regenerative piece or having this part of the regenerative practice or package this is what we're talking about, actually.
Mm-hmm.
It's ultimately, it's not about the device, it's not about the unit, it's about the patient, it's about the person.
Mm-hmm.
And if you can bring good results, that's what it's all about.
Mm-hmm.
That's why most of our referrals is actually word of mouth, because people actually find it very helpful.
Yeah.
And then they share the information. Yeah.
What happens in our practices, we really don't advertise much at all, because our patients get very good results and they're very happy about that, and they tell other people, and then those people with problems come to us too, because in our job we want the patient body, their body, to be able to adapt to healing mode.
Mm-hmm.
Which means they have to get out of a healing crisis, which means they have to be unstuck. And so if you can provide the proper environment, the body will heal.
And that's exactly what that is. I do want to mention briefly, there is a 4th of July sale and 10% off signature products until July 16th. And the code is July 4. July 4. Speaking of 4th of July, actually, how was the party?
It was great. It was fun. It's a very nice firework display. Amazing.
Oh, God, that was great. Nice. Yeah, absolutely. If you have any questions from the audience, we're happy to take that right now. But I do want to say if you want to follow Chuck, where do we find you?
So for me, I would just go to my website, which is Renner Integrative Manual Therapy. I'm also on Facebook. You can see then I try to post some information that's relevant, that's helpful. And then those things can be helpful to patients too. So you can find me in either one of those two places, either Facebook or my website.
Wonderful. And I also want to say that, if you're following us, this is the best commercial for a good internet company, by the way. So if you're watching this and you're having round 5 or 6 with us, God bless. You're a champion. Thank you, guys. Appreciate you. Follow us on Facebook and Instagram, and subscribe on YouTube if you haven't already. So I hope we are still on.
One question we have is about people that have had spinal surgeries. So if you have had a low back fusion,
like I have, for example,
you have, then really we can't do meaningful decompression on the lumbar spine.
But
we could do it on the cervical spine.
And that's exactly what we do.
Mm-hmm.
So
sometimes people have maybe a one-level surgical fusion, and then of the lumbar spine, and then down the road have more problems. But that doesn't discount you for all therapy. It just discounts you. You can't really complete decompression once you've had spinal surgery on that area. But you can have other treatment, and we also help many patients with improving the environment as much as we can.
Let's just a quick thing. Is it any kind of surgery, or is it just hardware that we're talking about?
Really just hardware.
Okay.
Really
so now let's say a person does not have hardware in their spine, but there was an emergency intervention of some sort, or are they a candidate?
They still are a candidate, yeah. So if you had some decompression type surgeries, but you haven't had a fusion, you don't have hardware, then you could be still a candidate once your MRI is read and approved and cleared. And so that's the case, yeah. So you still could possibly do it if you've had back surgery, just not if you've had back fusion.
Back fusion, right, exactly. Now, speaking of thoracic area, in other words, mid-level, is that something that you can work on with IDD?
No.
Okay.
So that's a great question. So decompression is only going to affect the parts of our spine that are more mobile. So we have a lot of mobility in our cervical spine. We have a lot of mobility in our lumbar spine. We don't have much mobility at all through our thoracic spine because of our rib articulations. And because of those rib articulations, you infrequently have discogenic problems through your thoracic spine. Now you can have thoracic pain and you can have things that I can help you with from a manual therapy basis to get out of pain. But typically you don't need decompression, and the decompression units are really not designed for thoracic area. They're designed for lumbar and cervical areas.
Perfect. And you can see the curve is a very different from thoracic to
Absolutely.
cervical.
Absolutely.
Now, there's a wonderful question actually. Would decompression, would that be therapy, be good for cervical spondylosis?
Yes, absolutely. So cervical spondylosis is essentially cervical arthritis for the most part. And so when you have arthritis, you have the structures that are getting closer together, and it's taking up space. It's taking up either disc space or kind of foraminal or nerve space. And so if you have something like decompression, again, you're creating more space for the discs. That space is giving more nutrition. Hopefully they're going to kind of puff up a little bit and separate those tissues that are rubbing against each other and creating more discomfort.
Wonderful. And last but not least, do you have any final, or should say final, but for the program, words of advice for the audience, something, just a brief summary so that we can kind of get a general sense of.
I think so. I think for me, it's like, if nothing changes, nothing changes. I have patients that have unfortunately lived with pain for years that didn't have to, because they were told maybe, hey, you're getting older, this is a normal part of it. Or, well, you had surgery on your low back, so expect to have this neck pain. There's really nothing else we can do. You're not a surgical candidate, so there's nothing else we can do. And that's just not accurate. I would suggest go to a holistic physician, go to someone who has maybe a different perspective, because a lot of times I just see so many patients in pain that just don't have to live like that. And so that's the main message I want to get out. Get an evaluation, get checked out, get something done, start moving the needle on your own. Because, I'll have patients that, maybe had the problem when they were 55 and now they're 63 and they've had this problem for like 8 years when it wasn't necessary. And that's what just kills me. I hate to see that.
And last but not least, is there an age that, let me rephrase that. What age category are we seeing here?
So we're seeing anything from probably 18-year-olds to 90-year-olds, 90-plus-year-olds.
So when somebody says I'm too old, does that make any sense to you?
It doesn't make any sense to me. The only person that says too old is someone from the outside looking in, right?
Thank you.
It's never really the person that says that. That's a label that they've acquired.
Thank you.
And so to me, it's about what you're willing to do. It's like, what are you willing to do to get your health back?
So I just want to, and we're almost here, done here, but there's a phrase out there. There is nothing we can do. I want you to forget that phrase. I literally want you to forget that phrase, because
Absolutely.
If you hear that, you're just not in the right place. Well, thank you, folks. Wonderful round 6, I think, on the internet, but we did it. We're champions. Thank you, guys. If you're staying with us, you're champions as well. And what we'll do is, we'll see you next week and with a better internet. God bless and thank you. Chuck?
Thanks.